Take it away, Michael.
Yeah, so thank you, Dr. Ferguson. Good afternoon, everybody. My name is Michael Nafi, and like what Dr. Ferguson mentioned, I'm a second year medical student at the University of Utah. And yeah, thank you for joining us today while I talk about stroke awareness and prevention, particularly how stroke can impact the Black community. Real fast, I just wanted to also thank Dr. Milani and her neurology team for helping me make this presentation and Dr. Ferguson in making this happen. Basically my goal at the end of this talk is I want you guys to feel confident in being able to recognize like what strokes look like, the signs of strokes, understand why they happen, and what we can do as a community and as individuals, and what you can do in lowering your risk. Okay. Why are we here today? Believe it or not, if you didn't know, strokes are one of the leading causes of death in the United States for Americans. Behind cancers, heart disease, and whatnot. More importantly, it's the leading cause of serious long-term disability, which basically means that even when people survive their strokes, they may lose like their independence or ability to go to work every day, or even their ability to communicate, especially if the stroke impacts that specific part of the brain. So like while strokes can affect everybody, the burden is not necessarily equal across all different demographics or population groups. So I have this figure or this image right here to show you kind of what stroke deaths look like between the year 2018 and 2020 for adults ages 35 and above. And as you can see here, the darker the purple basically means how the higher the prevalence of stroke deaths are. And as you can see here, so here's Utah right here. You can see that it seems like we're doing pretty good compared to other states. However, you can see here in the southern part of the United States, you see that there's a pretty high prevalence of stroke related death. And at that same time, guess what demographic typically lives in these general regions? The African American community. So, like I mentioned before, the risk for having a stroke is going to be different for every race and ethnicity. And there's been studies out there that show that the likelihood of having a first time stroke for African Americans is 2 times higher than compared to white adults. And in addition to that, for more particular in Utah, Pacific Islander adults also have a higher rate of stroke deaths as well.
Really?
Two Black friends who got significant strokes, one who died.
Real fast, Linda, if you don't mind muting your. No, you're good. You're good. It's happened to me. Anyway, thank you. Okay. When we're talking about stroke prevention, we're not necessarily just talking about health in general. We're also talking about how can we make this more equal and fair in when it comes to saving lives in different communities that are disproportionately impacted. I wanted the goal for us to be able to recognize what a stroke looks like, what can be done to decrease the risk of having a stroke, and how we can act when you see somebody having a stroke. Remember, it's better to be prepared to save lives overall, maybe even your own if you notice that you notice these signs. The way I wanted to go over this presentation is also using a case to kind of put us in a picture of a real life scenario. So let me introduce you to a 64-year-old male with a history of high blood pressure, high cholesterol, who develops sudden onset dizziness, imbalance while mowing the lawn at 2 p.m. today. He's also slurring his words. Everyday activity. He's in his 60s, in the hot sun at 2 p.m., and then develops dizziness, and he's now losing balance. What would you do if this was your family member in this scenario? Or what would you do if this was your neighbor or even your friend? Would you wait till it passes, or would you call 911? So I feel like these are kind of more rhetorical questions I want you guys to think about, especially when you see early signs of a stroke. This diagram right here, I just kind of wanted to show how labyrinthy this can kind of be. This is kind of what, on a clinician's perspective, what they have to basically deal with. I want us to basically particularly pay attention to the timelines on this side right here. And as you can see here that we have increments 10, 20, 45, 60 to 3 hours. And this is essentially the goals that clinicians and healthcare providers are trying to meet in terms of when a patient arrives to the emergency department for an evaluation after having a stroke or in the middle of having a stroke. And so, as you can see here, we have a goal of about 3 hours of being able to provide treatment for this patient because you will notice really soon that if we pass that 3 hour threshold or even a little bit even after, then our treatment is going to be changing. And with that treatment being changed, will also mean that potentially our outcomes are also going to change as well. So it's very important it's very important to keep in mind that I've heard a lot of neurologists say that time is brain, where essentially every single minute matters because you basically have no blood flow going to the brain. And so brain cells are dying minute after minute. Okay. So yeah, what is a brain stroke? So to simply put, a stroke happens to be when part of the brain doesn't get enough blood. And so we basically have two types. We have what is known as an ischemic brain stroke. And then we also have what is known as a hemorrhagic brain stroke. And the way I like to envision this is basically your plumbing system in your house. And so basically your blood vessels is the plumbing system. And so what happens in ischemic brain stroke, you basically have your plumbing system getting blocked by something, whether that's, let's say you have hair down the drain or you decided to flush the unflushable baby wipe. And basically you have blood flow that's being blocked. And so when you have blood flow that's being blocked, you're basically shunting or you're basically preventing nourishment or blood reaching to those cells. And when blood doesn't reach to those cells, then that's when you start having those cells slowly start dying. On the flip side, you have hemorrhagic brain strokes, where basically you have your plumbing system or your tubing system uh, rupture, essentially. So basically, let's imagine we have like a hole in one of your plumbing system, and now water is leaking everywhere. And essentially, that's basically what's happening in the brain when somebody has a hemorrhagic stroke. And so it's very important for healthcare providers to know the difference between the two because treatment is going to be very different. And just one other thing I wanted to point out is that ischemic strokes are a lot more common. And so treatment is most likely going to follow suit in what ischemic strokes are going to look like. And then at this point, I just want to know if we have any questions, see if anybody has any specific thoughts. Okay. So yeah, this is another diagram describing what the difference between the two are. As you can see here, this is an example of ischemic strokes, whereas here's an example of hemorrhagic stroke. And again, it's that idea of the plumbing system either being blocked or the pipes bursting in a hemorrhagic stroke. And what you can see here is these yellow plaques that are being built up inside the blood vessel. And that's essentially plaque buildup from somebody maybe having a higher cholesterol diet. And so this is why it's very important for us as patients to know our numbers when it comes to our various chronic diseases that we might have, whether that's diabetes or high cholesterol or even high blood pressure. Knowing these numbers will basically help clinicians know what we can do best to support these patients. And so basically, yeah, let's say a patient over the years continues to develop this high cholesterol diet, and you basically have this yellow plaque building up over the years. And eventually, one day, this blood vessel will be completely blocked off, preventing any blood flow, causing brain death to whatever region that blockage occurs. On the other side, where you have the pipe bursting, you basically have blood just leaking outside of where it needs to be. And then because blood is not going to where it needs to be, portions of the brain is slowly dying as well. So when it comes to spotting a stroke, there's this acronym known as FAST that we can use. And this may be the easiest way of remembering it. So you have face droop, arm weakness, and slurred speech, as well as what is the time to call 911. So basically, if you notice any of these symptoms, you don't want to wait. You don't want to drive the person yourself to the hospital, especially if um, knowing that time is brain and knowing that these are all time sensitive things. Um, and so calling 911 is essentially a beneficial opportunity for the patient to be able to go to the stroke center immediately. So yeah, again, we have our FAST acronym, pretty easy, just these four letters. Um, Image of describing what FAST looks like. Again, you have that face drooping. So typically when you have a stroke, face drooping, arm weakness. And so you're basically one side of the arm is going to be weak and weaker, or clinicians will definitely be able to spot that to see basically testing muscle strength and whatnot. You might also have speech difficulty. And then again, time is brain. So time is critical and calling 911 is very important. And I just want to let you guys know that it's not just limited to just the four symptoms that you might see. In addition to FAST, you might have vision loss. You might also have severe headaches, confusion, or even loss of coordination / balance, and then even dizziness as well. And so basically, I just wanted to let you guys know that you can have any sort of neurological symptom, and any of these symptoms need to be treated as an emergency. And so, yeah, this is supposed to depict of what vision loss might look like. You might be only able to see one side of the world, which might be indicative of a stroke or just some sort of neurological emergency. And again, just loss of coordination. So here's our first opportunity for an Amazon gift card. Hopefully you guys have been paying attention. So I wanted to ask, which type of stroke is the most common? I think I'm supposed to be, see, B. Nice, nice. Dang, Jasmine. I see that you put A first, then B, but then Linda, I see that you put down B first. So I think Linda was the first person.
My daughter is making fun of me for typing it out and taking too long. So
I think that's amazing. That's amazing. So yes, ischemic stroke is the most common type of stroke. And the reason why, partly the reason why is because the what leads to the blockage of blood vessels in ischemic strokes are due to the various chronic diseases that Americans have, whether that's diabetes, high cholesterol, hypertension. These all can contribute to ischemic strokes. And then I'll also talk about a little bit about lacunar strokes and then subarachnoid hemorrhages, subset of a hemorrhagic stroke, essentially. Okay, so the brain and where do strokes basically happen? So as you know, they all happen in the brain. Our brain is going to be fed by several major arteries. So you have basically the carotid arteries that will supply basically this front portion of the brain. And then you have your vertebral arteries that kind of come behind and then split up. Oh, sorry. And then it will split up into the basilar artery and the posterior cerebral artery and basically supply blood to this back portion of the brain. So it's very important for not only clinicians and I guess patients now to know or to somewhat know like where strokes can kind of happen with these different arteries. And essentially knowing that these different arteries can supply different regions of the brain, we now know that it's going to cause different symptoms because not every single part of the brain is the same. So you might have like let's say if you have a stroke in the middle cerebral artery, basically supplying this general region right here, you might have a patient who's going to be suffering more with speech and movement. Whereas if you have a patient who has a stroke in this general region, they might have more problems with vision and coordination. So again, different arteries is going to equal different symptoms. So moving on with our case, basically a family member, let's say like 30 to an hour, noticed that their family member was lying down. They called 911 and he was brought to the hospital by an ambulance where basically a code stroke was activated. And basically code stroke is a protocol where basically it's an emergency for clinicians to basically act appropriately. Okay. So when you come into the emergency department, what is going to happen is that we're going to grab a CT to basically assess the brain itself to see if we see sort of any blockage, any sort of blood leakage, and that's going to help us determine if this is an ischemic stroke or a hemorrhagic stroke. At the same time, we're also going to be obtaining quick labs and vitals, just so that we know, I guess, possibly what the cause of this stroke might be, what the stroke cause might be. So again, while all this is happening, we're all realizing that every minute matters. We need to realize when the last known well of the patient is. So let's say came in, we're most the family member is most likely going to say, "Oh, I noticed that he was on the ground around 2:30, um, possibly around 2 o'clock," and that's going to be information for the health providers to know what type of treatment is important for the patient. So going on to treatment, again, this is all very important because like this first bullet point right here, clot busting medications. This is very time sensitive. This clot busting medication is essentially going to break up the clot that's within the blood vessel, that blockage. However, because it's time sensitive, you can't just do this with every patient. And this is what is known as our first line treatment. So this is best case scenario with somebody who comes in a stroke. If we can, this is always going to be one of the first options. If not, what we can also do is known as a thrombectomy, which is for larger clots. And that's basically this figure right here where we basically insert this device and it travels up all throughout your vessels into your brain. And basically it's going to either vacuum out the clot itself or have this like fishing net mechanism that's going to essentially fish out the clot. And so, yeah, these two techniques or approaches are going to be used for ischemic strokes, whereas if you have a hemorrhagic stroke, treatment is going to be a little different. And this is more tailored towards lowering your blood pressure. And then if the stroke is bad enough, neurosurgery might need, or you might need neurosurgery in addition to that to make sure that it doesn't happen again, or we can prevent further complications from occurring. So with our case continuation, we find that he's admitted to the ICU for treatment and close monitoring. So by the time he's admitted to the ICU, his dizziness improves, but he's still walking pretty funny. So now he's requiring assistive device to help him get around. So that might include like a walker. He's in his bed, but he needs to use the restroom. He's probably gonna have to get out of his bed using a walker. So there's gonna be like little things that we probably don't necessarily realize in our everyday life that's going to be impacted once we have a stroke or when somebody has a stroke. So now he has to use a walker when he has to go to the bathroom or has to call for assistance. In addition, he's going to be spending the next couple of days undergoing stroke workup, lowering his blood pressure, and participating in physical, occupational, and speech therapy. So with him, we decided to get some labs. One of the first labs we got, this is A1C. Hopefully that's something that rings a bell. It's important for diabetes management. And what we can see here, 5.7, which is basically in the pre-diabetes range. What we obtained is the lipid panel. So what we got from it is his total cholesterol and some of these other values, LDL, HDL, and triglycerides, that will help us as clinicians know how severe their high cholesterol is. And as you can see here, these numbers are very, very high, or not very high, but at least out of range and definitely need to be addressed. In addition, we grabbed the blood pressure, and you can see here this very basic lab value. This vital sign will tell us so much. So 210/110 is a very high blood pressure, and essentially because of that, we're going to have to take steps to lower that. In addition, we decided to grab some imaging. So we did what is known as a CTA. We basically, I believe, like you're basically imaging like your portion of the neck and head of. You're basically looking at the blood vessels to see if there's any sort of blockages or any abnormalities. In addition to that, we're going to do an echocardiogram. basically imaging your heart to see if we notice that um, there are any sort of debris from your heart that may have traveled up to your brain, causing the blockage, if that's the possible source of your stroke. And then what we'll also do is, again, an MRI or CT to see if we notice any sort of lesions within your brain. And as you can see here, as we obtained his MRI, we see that he's obtained a lacunar stroke, what is known, just right here in this general region. And again, don't worry too much about interpreting these results. Of course, this is something that your doctor can help out with. And as you can see here, this portion is a little lighter compared to the rest of the brain, and that's somewhat indicative that a lesion has occurred. So we have his labs, we got his imaging. Now what's next? So now we're going to start some medications. And one of the first things we're going to start is aspirin therapy. This is basically an antiplatelet therapy that's going to help um, him not have any sort of this is going to lower his risk of having a stroke in the future, essentially. In addition to that, we're going to give him some statins, and those statins are going to essentially help him lower his cholesterol so it can get back to a normal value so that he has less plaques developing in his blood vessels. In addition to that, I mentioned that his blood pressure is very high. So we're going to control that with blood pressure medication. And it's not like that he's just taking these just right now to get better from his stroke. These are going to be medications going to have to be taken for the rest of his life to prevent another stroke from happening. So here's another opportunity to receive a gift card. Hopefully you guys, again, have been paying attention. Why does every minute matter during a stroke? So you have A, brain cells can regenerate quickly. B, blood clots get bigger the longer you wait. C, millions of blood cells die each minute without blood flow. EMS, or D, EMS cannot treat a stroke or cannot treat stroke patients. And I see from the chat, let's see, Jasmine, I see that you put B, Linda put C, which is correct. Michelle has also put C. Linda, because you already have a gift card, we're going to give it to Michelle. So congrats, Linda. I'm done winning. So yeah, Michelle, congrats. Yes, millions of brain cells are going to die each minute without blood flow. And that's why, again, this statement of time is brain is very important. Okay, let's see. Any questions at this point? Any thoughts? Just bent, needed. Okay. So the role of high blood pressure, again, I mentioned a lot how our patient had a very high blood pressure. Believe it or not, it's actually the number one risk factor for brain strokes. And so basically with somebody who has high blood pressure, your blood vessels are going to be decreasing in size, which is going to increase how fast blood is moving between each vessel. And because of that, that's going to lead to injury of smaller blood vessels, which is going to lead to what is known as lacunar infarcts. And along with that, we know that high blood pressure can contribute to other symptoms or other conditions, not only just strokes, but vision loss, heart attack, heart failure, sexual dysfunction, or even kidney disease. So why are lacunar infarcts so serious, silent? So again, hypertension or high blood pressure can cause lacunar infarcts. What makes them dangerous is that they're not actually as noticeable compared to like a larger stroke or one that you can see obvious symptoms that might correlate with the acronym FAST. That's because they're going to accumulate over time. And when you start seeing symptoms is when maybe you might see cognitive decline. And so high blood pressure is actually a risk factor for another form of dementia, which is known as vascular dementia, which is basically symptoms of cognitive decline. And so the talking point is that with lacunar infarcts, you're not going to have symptoms immediately. They're going to accumulate over time. And so once you start noticing symptoms, there's a good chance that these lacunar infarcts have been caught later in time, which is going to lead to poorer outcomes. And so this is just an example of the brain basically cut in half from splitting into a front half and a back half. And you can see that there are some blood vessels basically feeding into this central portion of the brain. And all of this right here is all high real estate. So another thing that neurologists will like to mention is that brain is like real estate, location matters. And all of this again right here is all high real estate. So damages to any of these regions right here is going to lead to a lot of symptoms. And so if this is all accumulating over time, it's going to be harder to have better outcomes, especially if you're not regularly following up with your doctor and checking up on your health periodically. So yeah, our patient had a lacunar infarct, and again, it was not noticed until then because of again his high blood pressure, his uncontrolled blood pressure, his uncontrolled cholesterol, as well as you can see that his diabetes or his A1C was approaching pre-diabetes range. So with all of this all these scary facts, what can we do about it? So basically, after somebody has a stroke, we have what is known as secondary prevention. And so that includes wanting to control your blood pressure, needing to control your cholesterol, as well as what does therapy look like. And so you might have your antiplatelet slash anticoagulation therapy or the aspirin that I was talking about. In addition to that, let's say if you had a stroke and now you can no longer walk or you can't speak properly anymore, rehabilitation with either physical therapy or occupational therapy might be needed. And then in addition to all of that, follow-up care. So as you can see, this one-time event is going to lead to lifelong changes for this person. So the goal for right now, we know that it happened now, and so we can't really do anything about the past. So now what we can do about the future is we want to reduce the chances of having another one, very which is very likely considering that once somebody has had a first one. Okay, here's another chance for an Amazon gift card. Uncontrolled high blood pressure increases the risk of what type of stroke? See what we got in the chat. Gabe, nice. So yeah, it seems like most people are saying A. So yeah, Gabe, I think you got the gift card. Yes, it is lacunar stroke. Um, and again, this is going back to the same uh reason of why that like high blood pressure increases the chance of lacunar strokes because you're damaging tiny blood vessels, and those tiny blood vessels are not because they're not as big, you're not going to notice these symptoms, and they're going to accumulate over time, which makes it very dangerous. Okay. Jasmine, I see you have a question. Let's see. Is stroke hereditary in any way? Um, this is coming from a medical student. I'm sure Dr. Milani might have more on this. I want to say it can be to an extent, especially if you have a family history of other chronic diseases such as high blood pressure, diabetes, or anything that might increase the likelihood of having a stroke. So I would say to an extent, yes. But having a stroke itself, I wouldn't say is necessarily hereditary, but the causes of a stroke, I would say yes. Dr. Milani, I don't know if there's anything you wanted to add to that.
Yeah, I think that that's absolutely right. So the risk factors for stroke can be associated with genetic syndromes, and then there are some very rare stroke syndromes that are genetic. So there can be true stroke syndromes that are related to genetic diseases in families.
Nice, nice, nice. Okay. Good question, Jasmine. All right. So we're continuing with our case. I wish I gave him a name, but I didn't. But so again, this one single event is going to cause many lifelong implications. And that's going to include daily medications that he's going to have to take for the rest of his life. That might include aspirin, these statin medications, and blood pressure medication. He's going to have to follow up with whether that is his neurologist, cardiologist, his family care provider, her family physician pretty regularly. And then who knows if he does have a disability, such as he has weakness on one side of the body, or he has trouble walking now, or his speech deficits. Now that's something that we're gonna have to take into account. And then again, loss of independence. He might not be able to do activities of daily living anymore. He might not be able to go to the grocery store by himself anymore. He might not be able to work. And again, with all of these facts, it's good to notice that or point out that the likelihood of having a stroke again after having the first one significantly increases. So it's very important once somebody has a stroke to make sure you follow this a checklist of how we can prevent another one from happening. Okay, so brain strokes and how it relates to the Black community. So if we now zoom out, why does it matter so much for the Black community? The reason why is because we see higher rates of chronic diseases. And I mentioned time and time again in this presentation that these chronic diseases are basically risk factors for strokes. And again, hypertension or high blood pressure being the number one risk factor for strokes, and how prevalent it is within the Black community, as well as diabetes, because there are higher prevalence of these chronic conditions within the community. That means it's going to basically mean that the likelihood of having a stroke is significantly higher. In addition to all of that, there's going to be delays in diagnosis and treatment. There might be, knowing that there's been historical mistrust with the healthcare system within Black communities, there might be delays in getting an opinion or advice from clinicians, or even updating or basically following up with your family care provider, and basically with your preventive treatments, your diabetes, your hypertension. And again, this all goes back to the idea that the sooner we catch it, the better your outcome might be. And so, again, if we're catching this like 2 or 3 hours later, and then you basically get here another 3 hours later, and now it's been 6 hours, we're gonna have to change our entire plan in terms of what treatment is gonna look like. And because of that, you might have poor outcomes. And again, this is basically just reflecting how that these are not necessarily just like medical issues that the Black community is also facing. These are this is also structural challenges that the Black community are also facing because of the societal pressures that have been placed. So in addition to that, we have what is known as social determinants of health, or social determinants of stroke risk. And these are all going to contribute to the health of individuals overall, because we know that your health isn't just about biology. It can be shaped by how wherever we live and the access that we have, or the resources that we have access to. So that might include like food deserts, and this is basically an image of what a food desert kind of look like, or the image of what a food desert look like. You basically have no access to grocery stores or places with healthier foods such as vegetables and fruits, and all what you have in your community are going to be fast food restaurants. And so these food deserts are going to contribute to people having a higher likelihood of developing chronic diseases of high blood pressure, high cholesterol, or even diabetes. In addition to that, now our patient has to take aspirin, blood pressure medications, and statins for the rest of their life. Are they going to be able to afford all of those different medications? That's something you also got to take account of. And then in addition to that, strokes don't discriminate. And so anybody can have a stroke. And so whether, let's say English is not your first language, and then you present to the emergency department, health literacy is going to be all very important, as well as language and being able to communicate with your provider. Along with all of that, access to different facilities. So now let's say your doctor says you need to do rehab for like 6 months to regain the strength in your legs. Hopefully you live in an area that you can do so, or let's say you have to commute somewhere. All these, you have to basically account for all these things that are going to be changing this person's life now once they have this singular event. Okay, another opportunity for a gift card. So again, in the FAST acronym, what does the S stand for? Ooh, somebody was very fast, very fast. Let's see. So I see Linda put A, Jasmine put A. Jasmine, let's go. Okay, I believe Jasmine was the winner in this. So yeah, mostly
However,
A.
only one. You can only win once.
Did Jasmine only? I thought Jasmine has not gotten one, unless.
So Dr. Venner made a typo and said she wanted, if she was being the winner, she wanted to go to Jasmine.
I see. Okay. Well then, Michael, Richard, I think you're next up. So yes, slurred speech. Um, and again, um, the FAST acronym is very powerful because it's very short and anybody can really learn it. And you might be able to save somebody's life someday. And all these other symptoms, they might be present within somebody's having a stroke, but not necessarily. It doesn't mean anything in the FAST acronym. Okay, so with all this information, where do we go from here? Basically, we have what is known. I kind of created this checklist, this prevention checklist. I think if we kind of keep these things in mind, this can definitely help lower the risk of having a stroke, and definitely teach people about what to do and when you want to spot or when you can do in spotting a stroke. First one is exercise regularly. A Mediterranean diet. There's been studies that show that a Mediterranean diet that consists, and I don't know exactly what is within these diets that basically lower the risk. I believe it's using less Western type diets, such as that includes like high fructose corn syrup or trans fats or saturated fats or items that basically are just going to bump up your blood pressure or your cholesterol, whatnot. Knowing your numbers, so knowing your A1C, your blood pressure, and your cholesterol, and making sure you're staying on top of that, getting these values into a level that's manageable and controlled. And then also taking your medications as prescribed. I know sometimes I've had, at least as a second year medical student now, only second year, I've had patients already tell me like how they've tried rationing their medications because of affordability and whatnot. Yes, those are things that we need to take account for, but not taking medications as prescribed can definitely lead to further complications and whatnot, or your medications might not be as effective as if you're not taking them every day. And I didn't touch on this topic too much in this presentation, but quitting smoking or limiting your alcohol intake definitely can go a long way in preventing strokes from happening. Um, just like hypertension or how high blood pressure can contribute to is a risk factor for many different diseases. Smoking and alcohol are risk factors for multiple diseases as well. And so basically, if you have all these chronic diseases and you're also still drinking and smoking tobacco, you're definitely just increasing your risk of having a stroke uh, in a very, by who knows, like tenfold or so. In addition to all of that, I think teaching somebody fast is also something that you can do. Basically, take one and pass it on type of ordeal. Where again, I have this acronym right here: face drooping, arm weakness, speech difficulty, and time to call 911. Again, super fast. You can teach anybody, and hopefully, the whole idea is that we know that strokes are preventable and treatable. So, I guess the best way we can do is act quickly and consistently, especially if we're knowledgeable about them. So in terms of resources, I plan on working with somebody on getting like a whole stroke resources page uploaded on the BPOU website. And so basically just under the resources tab right here and somewhere along right here. You can also look up American Heart Association. They also have a lot of facts about what you can do to and taking care of yourself and preventing a stroke from happening. But yeah, and also, yeah, talk to your doctor if you have, especially if you have any questions or any of your healthcare providers that you in contact with. But yeah, that was pretty much about everything. Yeah, thank you guys for your attention. I would love to hear you guys' questions and thoughts.
Good presentation there, Michael. I had a question for you.
Yes.
All right. So, is the incidence of stroke in our nation increasing or staying about the same?
That's a good question. I'm sure I don't know that from the top of my head. I would like to say I hope it's staying the same. Um, and if not, then if it is increasing, I'm not sure if that's because we're finding out that they're happening a lot more often, or if it's because um, there's been a shift in towards maybe diet or prevention management that's increasing the prevalence of stroke. But I'm not exactly sure. I don't know if Dr. Milani, if you have a more concise answer.
Yeah, actually, the incidence of stroke has decreased over the last few years.
I have a follow-up question to that, Dr. Milani, actually. Do you know why that is, if they've mentioned that?
Part of it's thought to be sort of like a better understanding of like a change in diet, more so to whole foods, less processed foods. And so though the stroke risk is still incredibly high, roughly 1 in 6 deaths in the US are related to stroke or cardiovascular disease from leading to stroke. Overall, and a better education in terms of like dietary modifications and moving away from ultra processed and highly processed foods to whole foods has helped affect the incidence over time.
Thank you, Dr. Milani. I also see a question here by Jasmine. She basically asked, in my experience as a second-year medical student, has there ever been anybody who's fully recovered from having a stroke? I personally have not necessarily seen, and I'm starting my second year, so I feel like this might be a better question for Dr. Milani. And I want to say yes, I think it's totally possible. Especially depending on what the stroke is, where the stroke happened, and how soon we were responsive to it. But yeah, Dr. Milani, I don't know if there's anything else.
Yeah, absolutely. You're right. So you can have a full recovery, and the bulk of that comes down to where the stroke is, the type of stroke, and the time to intervention being key.
So I can give a personal example of that. So during, of course, many of us have gone to remote work. And during my day job, many people don't know, I'm a chief medical officer with University of Utah Health Plans. So I'm kind of like the chief doc for insurance. But during one of our calls, one of our nurses started to actually slur her speech. And then she started to have facial change. Luckily, she had her camera on. And we can say, and that's actually what saved her, because she happened to be in a role where someone else recognized it. But if she didn't have her camera on, she didn't realize she was changing. Because often when you're going through the symptoms, unless you're in front of a mirror and you don't, and it's not that dramatic, it can be subtle. Because I'm sure we've also seen live television where someone's on the news and they actually started to go through the signs of FAST, or excuse me, they started to show the signs of a stroke. And this happened. However, she got care quickly. She was in the South Salt Lake area. One of the nurses that was on the call called for her. She was over 60, had a history of hypertension. And then she was immediately taken to the ED and got the emergent intervention. She is now 1 year out and fully recovered. And she was over the age of 60. So it can happen. Often I feel what's more protective is youth and sort of that when it does occur. There's less plasticity and resiliency in an older brain than a younger brain. But I think someone recovers better if you're 40 and you incur a stroke and you don't have a ton of risk factors, as opposed to you're 80 and you incur a stroke. But yes, it definitely, you can fully recover. I don't notice, I think maybe it might notice if she's very fatigued that her speech may change, but other than that, no permanent effects.
Thank you, Dr. Ferguson. I see another question, Jessica. How can someone with a family history of stroke be more proactive in prevention? So yeah, let me just go back to this slide right here. I think this slide kind of summarizes everything in terms of what you can maybe do in terms of preventing stroke from happening. And I guess I think it's also good to follow up with your doctor and ask them the best ways that you or your family can go about preventing a stroke from happening. But yeah, basically exercising regularly, and this might be from like just not going on a walk at all to like now going on a walk every like 2 weeks or every 2 times a week, just around the block or the neighborhood, or doing 10 push-ups if you can, and little things. I feel like increments is better than nothing, as well as Mediterranean diet. I think that obviously not everybody's familiar with that, and so I think um basically limiting your salt and bad fats intake definitely can help and go a long way. And then also knowing your numbers. So this goes back to following up with your provider, knowing these numbers, and then taking your medications as prescribed. And if you or somebody that you know is currently smoking tobacco, I think this is a good time, especially with a family history of strokes. I think this is a good time to have a conversation about quitting and then limiting alcohol. And go ahead and teach your family members, considering that it seems like stroke might be a prevalent thing in your family. Go ahead and teach somebody fast in your family and kind of spread the word that way. So hopefully that answered your question. And again, we're going to have additional resources on the BPOU page under resources